Hello and welcome to the New School OBGYN podcast, a podcast in women's health, but for everyone. Our goal is to promote good and reliable knowledge because the source of your information matters. My name is Eric Schmidt. I'm a board-certified OBGYN, and today I have with me, again, Dr. Amy Buben. Welcome back.
Hi, thank you.
Please consider downloading and following along. We're on all the major podcatching hosts, and check us out on YouTube for the video podcast. Today, Amy and I are going to go over C-section or Cesarean section or delivery. As part of the labor series, we have to go over this. And so again, Amy's background, she works with us as a laborist, and so she's managing a lot of our patients and managing C-sections too. Amy is from here in the University of Washington, did her school and residency in Texas. And so what we'll go through today is, well, what is a C-section? How common is it? What are some of the reasons it's needed? We'll even do kind of try to be as complete as possible for a walkthrough of what it might be like. Go over complications and frequently asked questions that we get from patients or other people's. So welcome back. I'm post-call today, so hopefully I do okay with this, and there's less or not too many more than I usually do.
Did you have any C-sections yesterday?
We did. We did, yeah.
No, just common procedure.
Yeah, it is a common procedure. That was a good segue.
Thanks.
So exactly what is a C-section? It's delivery of baby through the abdomen. And how common is it, Amy?
Yes, it's the most common surgical procedure in the U.S. Almost a third of all deliveries are via C-section. Yeah. And there can be quite a few different reasons why it's needed. So I think Eric's going to go over a little bit more scheduled C-section reasons. But if you come in labor and you're planning on having a vaginal delivery, there's really three big reasons that we talk about doing a C-section. So the first would be if we can't get your cervix to dilate. And we have a lot of different ways to get the cervix to dilate. But if it doesn't dilate, you can't have a vaginal delivery because it can tear the cervix. So that's when we talk about a C-section. The second big reason we talk about C-sections is if you do dilate to 10 centimeters and then you push and you push and you push and the baby is just not fitting through the pelvis, then we also talk about a C-section. And the last reason is what we call fetal distress. So fetal monitoring, which could probably be its own podcast, but or series, but it is how we look to see how baby is doing. And if baby is showing us signs of distress on that monitoring and we're not going to have a delivery very quickly, then a lot of times we'll talk about a C-section for baby's well-being. Yeah,
and so a lot of those are, when we call it intrapartum or when labor is happening, trying for a vaginal delivery, and reasons come up where a C-section may be needed, but there's also potential situations where we can't even try labor, and so that would be more of we call scheduled C-section, because there might be issues with the placenta, like placenta previa you may have heard of, where the placenta covers the opening of the cervix, and so we cannot safely do vaginal deliveries in those situations, or if babies breach and not in labor. Basically any way that would be unsafe to have baby vaginally for both mom or baby reasons. Okay, so I think maybe it's important we go through or try to walk through what it'd be like, and we'll start with the scheduled C-section. How does that process normally work? And mainly we'll talk of the day of the procedure. Patients are usually coming in fasting. They're kind of the old way of the thought is, about 8 hours of fasting, meaning nothing to eat or drink for 8 hours prior to the scheduled C-section time. With some more discovery that maybe it doesn't need to be a full 8 hours, because that actually might help with the post-op recovery and healing process if a patient isn't fasting so long. So different institutions might have, or different hospitals might have policies that are, some might be 8 hours, some might be 6 hours, some might be 2 hours. You really have to check with your own location for that. And a lot of that is for the anesthesia reasons. But you'll likely have your blood drawn. We're going to want to know the blood counts, because with deliveries, there is an increased chance of extra bleeding. So we want to know where patients are starting from, and also do a thing often called a type and screen, know the blood type. So if there is an emergency, we can quickly move to try and get extra blood for a patient if there's extra bleeding.
And these are things that you will typically have drawn if you come in for a vaginal delivery as well. So they're pretty common labs.
Right. There's still a risk whether it's vaginal or C-section for extra bleeding. And then skin prep. We want to make sure that the area where the C-section is going to be performed, which is usually just at or above the pubic hair, is nice and clean. And so you might get some wipes to do at home and maybe the morning of surgery, and then for sure right before the surgery in the operating room. But when you're in the operating room, you'll get a Foley catheter placed, and this is to try and get the bladder out of the way, because the bladder, the urinary bladder, is actually very close to where we perform the cut on the uterus, because we want to try and get as low as possible on the thin part of the uterus. And we'll talk about it probably more in the next podcast about why we want that. But we want that scar on the uterus to be on the thin part of the uterus. So we want that bladder to be empty, so it's less in the way, less chance of injury, which is a potential risk of a C-section. And
spoiler alert, we want it on the thin part, so you could potentially have a vaginal delivery in the future.
Yes, thinking ahead.
Yes.
And you'll get anesthesia for your C-section, obviously. And if it's a scheduled C-section, generally this is a spinal anesthesia, because spinal anesthesia does a better job of not only giving you the anesthesia part, or the lack of pain, probably about below the ribs down, but also it helps to relax the muscles better. We as C-section providers, definitely, I prefer a spinal anesthesia much better. But in situations where maybe a patient's laboring, they have an epidural, that can be dosed higher, so you can use an epidural for your C-section, so you don't have to have another poke in the back.
Yeah, and I think the biggest thing is to know that we will test and make sure that you're comfortable before we do the C-section. So if we are using an epidural and you're not comfortable, depending on the scenario, it's always possible to replace it with a spinal.
Yeah. And also, I guess, building on that, sometimes when we're doing these C-sections, patients can feel some pressure. The goal is definitely to take away a lot of that, or all of that sharp pain, and make it comfortable. But during the whole process of a C-section, there can be points in time where someone may feel some pressure, whether it's when we're pushing the baby out or things like that. But for sure, majority of all the painful situations should be taken away. Because we're doing a laparotomy or a large cut incision on the belly, we give antibiotic prophylaxis, and our surgeries are deemed kind of a clean contaminated is the label, because there can be some bacteria, especially if someone is laboring, but the uterus does connect with the vaginal canal where there is bacteria, and so we want to give antibiotics at the time of the C-section, or before we make that skin cut, to help reduce the chances of an infection later on down the road. And so let your provider know if you have any allergies to antibiotics. We put little compression devices on the legs to help prevent blood clots. This is done before, during, and after your C-section to keep that blood moving in your lower legs, because it may be... Okay, that was my post-call slur.
Happens to all of us.
If you're not walking normally and you have a C-section, you have a little increased risk for what we call a DVT, or deep venous thrombosis, or blood clot in the veins of the legs or extremities that can go to the lungs and be very dangerous. And so that's why they put those little compression devices around your legs. And then we put the surgical drapes up, and that's when we test the skin to make sure that the patient is comfortable and not feeling any of that sharp stimulus. Are you going to anything?
Yeah, I was just going to ask, so I know you'd mentioned spinal and epidurals. What happens if we can't get your pain controlled at all?
So there are rare situations where either the spinal isn't working, or the epidural isn't working well enough, or it's too emergent to do either of those things. In those situations, again, rarer, patient might go under general anesthesia and be completely asleep for the C-section. Not the ideal scenario, but it's something that happens when things, it's the last resort.
Yeah. And I think a lot of people, or there may be an assumption out there, if you're in labor and then you need a C-section, that it's an emergency and that you're going to go under general anesthesia. And that's not necessarily the case. So unscheduled C-sections or C-sections that you need while you're laboring for baby's heart rate or your cervix not dilating or pushing for a long time, the things we talked about previously, sort of depending on the scenario, the majority of the time we're going to be using a spinal or an epidural. If it's something where we need to get the baby out within a matter of a few minutes and you don't have adequate anesthesia or adequate pain control, that's really when we're talking about a true emergency section in general anesthesia. Mm-hmm. But the majority of unscheduled C-sections, it's going to be a discussion about why we're needing a C-section, and then the process itself is very similar to a scheduled C-section, except for the fact that you've been laboring ahead of time.
Yeah.
And we don't wait for fasting. So it's we're not usually going to wait 8 hours from talking about a C-section to do a C-section.
We're going to emergently do it in 6 hours. Yeah.
So the procedure itself, a lot of people ask, what happens during a C-section? And just kind of starting from the basic, once we make the decision you're going to have a C-section, you're coming for a C-section, you'll get moved to the operating room. Most of the time, we'll have you get onto the bed. We'll make sure your anesthesia is adequate. And then if you're having partners that are going to be joining you, they'll either join you before we make sure your pain's controlled, or after your pain's controlled, they'll come into the room and join you as well. So we do that scrub that Dr. Schmidt was talking about, and then we wait 3 minutes for that to dry. And that's kind of this awkward time where oftentimes you feel very exposed, but we're allowing that scrub to dry, and then we place that drape up.
I bet patients wonder about that. You know, as we're just kind of awkwardly standing around the bed after we scrub the belly, and
yep. And then
I haven't thought about that. I mean, I think about that at the time, but yeah, that's a good point.
Yeah, and then we talk about you too. We make sure we're doing the right procedure for the right person. That's called a timeout. Always very important in surgical procedures. But once we've gone through all of that preparative part, we put the drape up, and then we test again. So again, we make sure we actually pinch you fairly hard with a little tester that makes sure that you're comfortable. And once we know that you're not feeling those pinches, then we start the C-section. I know Eric had mentioned this as well. It's really common to feel tugging, pressure, pulling. It's also very common to be nauseated during this time, as well as itching that can be from the spinal or the medicine itself. Anesthesia is wonderful about making sure we help with all of those things.
And you can even let them know, hey, I get pretty nauseous with anesthesia medications or something like that, and they can potentially try to give you some preventatives for that nausea. I think absolutely. We generally do too. Yeah.
I think we'll typically give you something. On a side note, we also give you a shot of this little medicine. Sorry, by shot I mean you take a little shot glass worth of a little medication that helps neutralize stomach acid. So you can sort of expect that preoperatively also. Yes, you drink a fluid, not an actual injection. But sorry, back to the C-section. So once we know you're nice and numb from feeling anything sharp, we start the C-section. And the incision, just as Eric had mentioned, is side to side, kind of right above the pubic hairline, or it's a bikini cut is what I've heard people often refer to it as. From the time that we make the incision to the time of the baby being born is usually within 10 minutes. It kind of depends if you have a lot of scar tissue or other things going on. It can take a little bit longer, but usually getting to baby is the quicker part of the surgery. Once baby's born, then putting everything back together is what takes a little bit longer. And most C-sections are going to take anywhere from 45 minutes to an hour and a half, just depending on complications, how difficult it is, multiple factors.
Let's talk about the skin incisions a little bit. Because, I mean, there is a couple of different ways to do it. There's, we commonly describe it as like the Fan and Steel and the Joel Cohen as like the side-to-side bikini cut. It's, but then people might, see vertical skin incisions, kind of where it's going from the pubic bone and then up straight in the midline towards the belly button. We don't generally do that. There were some studies back in the day where you would potentially have like decreased bleeding because not a lot of those blood vessels in that region cross the midline, and so that area can be a little more avascular, we call it, or not have those blood vessels. But we've, I think, become so efficient with doing this more cosmetic, low bikini cut that it's really mostly like other countries where these vertical skin incisions are being done. Would you say?
Yeah, I would say the majority of the time we're going to be going on that side to side versus the up and down. That being said, some people who've had surgeries previously that have an up and down incision, it becomes a discussion whether or not you want another up and down incision or whether or not you want a side to side. And honestly, I find the majority of the time people will end up doing a new incision, even though it gives you a new scar. Maybe you disagree.
I wouldn't say I disagree, but I I would say most of my patients and that might have that, because we might start that conversation in the clinic too, where you know you're seeing that prior vertical skin incision, and you're like, well, you know, we usually do it side to side on the bottom, or do you want me to use that same skin one? I would say 75% of the time patients request the same incision, and the recovery and pain might be a little easier with the lower one, and that might be a reason to switch it. But yeah,
it's going to be a conversation between you and your provider, whether or not this is scheduled or unscheduled, which incision, if you have had a prior incision that's up and down, which one you would like to do. But just knowing that it can be performed both ways.
Ooh, a question we get often too. Yes. Do we cut the muscles?
Not commonly. So the majority of the time, the muscles are separated. So your muscles sort of naturally separate at the midline. It's pretty uncommon to cut the muscles. There's a technique where we do, but that's
I think that's technically in the jewel colon, right? That type of, anyway. I'm getting my names mixed up maybe, but
You're good.
Yeah, it's more of a separation of the muscles than a cutting of the muscles. If someone has a lot of scar tissue, I think that's a situation where you just need to be able to make room, and you can't safely make it in the normal area or stretch it in the normal way to make room to get baby out. Or if there's more emergent situations, you're having difficulty making the room to get the baby out, that might be the situation.
Yeah, and also on that note, I have had people occasionally ask, oh, they must have cut my muscles because I have this gap kind of between my muscles. On a side note, that's common during pregnancy regardless. It's called diastasis recti. And so that doesn't necessarily mean that your muscles were cut or not.
Yeah, good point.
It's that can happen with a vaginal delivery. Yeah. So that's just a bit separate from it.
Yeah.
So once we make the skin incision, and then there's something called the fascia, which kind of keeps all of your abdominal organs inside. We have to get through that, and then through the muscles, and then we get to the actual inner part of your abdomen. So that's going through what we call the peritoneum, which is the thinner layer that sort of surrounds all of your abdominal, everything in your abdomen. And then we see the uterus. So what do we do once we see the uterus?
Well, at that point, you're pretty much ready to get baby out. In my teaching, and I think some years past, and I think this trend is changing, we did this one thing called the bladder flap, where we make this superficial cut on the uterus and try and push away that bladder. Because like we talked about before, the bladder is kind of attached to the lower part of the uterus, just inferior to where we want to make the incision. But sometimes in a laboring patient, that bladder seems a little higher, or if there's a lot of scarring from previous C-sections, that bladder can be scarred up even higher. And again, we want to make that incision ideally in that lower part where it's thin for a number of reasons. And so sometimes we do have to create this bladder flap, but the trends have been actually not to do this. And I agree with that. So if there's any young doctors listening to this, bladder flap isn't maybe so necessary.
I would agree. I rarely do a bladder flap. But if you ask your surgeon and they say, I always do a bladder flap, that's not a problem either. No, it's just different ways of doing it.
And so then, we're and after that, we're making the cut to get into the uterus with baby. And then we do that and gently stretch the uterus open and get baby out. And at these different times too, when you're going through C-section, maybe I'll go back, you can feel more increased pressure whether or not you have your spinal epidural or whatnot, because of the bluntly separating the muscles and then the separation, then delivering baby through the uterus. Often the provider is pushing, because there's no pushing force like in a a vaginal delivery, the patient is able to create that pushing force. But just sitting there in the C-section, we can't just palm the baby's head and say, "Rah, come out of here." No, you actually need to create some force, and so that is done by usually the assistant pushing the baby's butt or head, if baby's breech, towards that incision, and then baby's delivered. And if everything looks great with baby, we try to do the delayed cord clamping, just like we would do with a vaginal delivery. It's a standard of care, and it should be, but good always to ask about. And so we'll do that delayed cord clamping. I leave the cord a little extra long, so pass it on to the nurse, and then if the support person, father, baby, whoever it may be, wants to go over there and cut the cord to its final length, they can have that experience too.
Yep, I absolutely agree. Just kind of going back to the hysterotomy briefly, or that's that incision on the uterus itself. I know we talked about the skin incision side to side or up and down. Same can be true of the uterus. So very rarely we'll make an incision up and down on the uterus, and that's reserved for often where that lower part of the uterus isn't thin enough to make the incision, or if it's a particularly difficult extraction or getting baby out of the uterus. But it's kind of a segue into the next time. But it's important to know, if you have an up and down skin incision, that does not mean your uterus is up and down. And when you hear doctors talk about what type of incision do you have on your uterus, no, that's the one that you can't see. That's not the one that's on your skin. Very, very
It's the one we care about.
Yep.
The skin doesn't matter as much. We like to have a nice cosmetic, good-looking skin incision, of course. But we really care about what has been done with that uterus in the past. When we talk about VBAC, spoiler alert, it's the next one, and the next talk. So that's the one we really care about. It increases our suspicions if someone had a preterm C-section, especially under 28 to 30 weeks, because that thin part of the uterus hasn't developed yet. And so often you maybe have to create that up and down incision. And so if someone for some reason unfortunately has to have a C-section and they're 26 weeks pregnant, it may be that up and down cut on the uterus, which again we'll get into.
And this may be, going off a bit on a tangent, but people will sometimes ask about a gentle C-section. So at our hospital, we don't have the drapes that are clear where you can see through at the time of delivery, but there are those drapes that exist, and depending on your institution or where you're delivering, that is something you can ask about.
Shout out to my residency. You don't know this, by the way.
Did you guys do gentle C-sections?
We did a study on it.
Oh.
And I was part of that. I didn't see it to the end.
Okay.
Graduated. But initially I did some help. Research isn't my thing, but I helped a little bit on that one.
Just podcasting.
Podcasting is my thing. I'm so great. But yeah, I had that in lower. We can get on that too, but
you have it down there. Sorry,
it's okay. Just to finish that thought, gentle or family-centered C-sections. Basically, we're trying to make it as good of an experience as possible to promote that first initial bonding between mom and baby, just like we would for a vaginal delivery, and that means skin-to-skin contact. Maybe be able to see the birth of the baby by the mom or the support person, and then baby basically coming right over to mom's chest and getting that skin to skin, maybe early breastfeeding, and just know that if you are needing a C-section for whatever the reason may be, it doesn't mean that all of your wants and dreams are totally thrown out the window and you have no choice in anything. Our goal is always to make sure you're safe and your baby is safe. But if there are things that you want, I had a patient recently ask me if they could play a song in the operating room. Sure. You sure
absolutely. If there's specific
what was the song?
things, I don't remember.
Oh, okay.
It was very calming. That was Celtic
Taylor
music.
Swift? Oh, okay.
But ask your provider. And we can't always accommodate everything, but we certainly try to accommodate those things that don't impact safety.
So we just went over a lot of the procedure, and a good thing to talk about always when we talk about these things as well. What are my risks with a C-section? And with any surgery, especially major surgery, we talk about there's risk of bleeding, infection, damage to the surrounding organs, tissues. That also does include baby. There's a risk of the blood clots, infection afterwards. Basically, all the things we do to prep you is a way to hopefully prevent one of these complications. So all the things we talked about before. So during a pregnancy, the body, the mom is building up their blood volumes to get to a point where, as if there's just to support if there was extra bleeding with a delivery, because we potentially say that the mean blood loss for a C-section is around a liter, which can be a lot. But that is that's the threshold where we say if it's above that, that's what we call a hemorrhage, and below that is considered kind of normal. Often, if it's scheduled, it can be much less than that. But there are situations where, bleeding can be quite a bit more than that too. And so, go ahead, Amy.
Oh, no, I was going to mention, it sounds really scary, and you might hear bleeding. Oh my gosh, I definitely don't want a C-section. Bleeding can happen with a vaginal delivery also. Yep. So this risk is not exclusive to a C-section. One of the big reasons called atony, which is where the uterus doesn't clamp down or shrink after baby is born, that cause of bleeding is a possibility during a C-section or vaginal delivery. Yeah. So not to scare you from having deliveries.
Right.
It's important.
Yeah, that's a good
But just
point.
knowing it's not just specific
exclusive to C-section. Yeah. And we talked about prevention of infection earlier with the antibiotics. We might give additional antibiotics if someone has labored, or we might do a vaginal prep if someone has labored. There's some evidence to support that.
But then how do you do vaginal seeding if you've prepped them?
Oh, you
Sorry.
just exposed us to a whole nother topic. We'll come back for another podcast on what vaginal seeding is.
Sorry, infection risk though.
And so, and then kind of the long term, in the days to potentially weeks to follow, there is a potential risk of a wound infection too, of that incision, or endometritis, which is infection of the inside of the uterus afterwards. Both of those things can happen. And so if you're having fevers after your C-section, let your providers know immediately or come to the hospital. We talked about the potential damage to surrounding organs or tissues. That's why we put that Foley catheter in. That's why we make sure that bladder is far away from where we're making the incisions, or the blood. There's a lot of blood vessels in the area in the uterus. There is, very rare risks of potential harm to the baby with C-sections, just like with vaginal deliveries. But I think it's worth just saying, that's a possibility, although be it very rare. And so, those are some of the risks associated with that. I'm going to go ahead.
Oh, the only other risk I would mention, I know we talked about this a lot, is pain. And I think of all the risks, that's really the one that is not so much a risk, but will happen. Having surgery can be uncomfortable afterwards, but we have great regimens to have you on, and we make sure your pain is, we can't make it zero, but controlled, and you've got a regimen when you go home. So that's just the only other thing I usually add when I'm talking about risks to C-section. Yeah.
And then probably something that's not talked about maybe enough that we did touch on in the causes of bleeding podcast. But like sometimes with C-sections, you're distorting that natural interface of the uterus. And so, there can be some issues with bleeding or painful periods after C-sections. It's kind of a little more of an afterthought, but, I'm finding, I feel like more and more that, patients are having increased pain if they've had multiple C-sections potentially later on in life. So something to keep in mind if you have had C-sections and your periods are heavier or more painful, let us know.
Yeah. There's other things that can happen during C-sections other than the C-section itself. So if you have cysts or things, which is kind of getting outside of this particular series, that can be something that can be taken care of. But specifically a tubal ligation or a sterilization is one thing that we offer during C-sections. If you want to speak more to how we would
so generally towards the end of the prenatal course, or at any point really, you could start to talk about if someone is desiring more pregnancies, and if they're 100% certain they don't want any more pregnancies, and they would want a form of permanent contraception, tying somebody's tubes or removing the fallopian tubes during the C-section really doesn't add much. It's pretty easy to do, might add a few minutes, really low risk of any potential complications from that. And so while I am a big advocate for the gentlemen to get their vasectomies instead of a woman undergoing a tubal ligation or we call it bilateral salpingectomy or removing the tubes, if we're already kind of in there performing a C-section, it really doesn't add too much risk or time to the procedure to get your tubes tied. So talk about that with your provider if you are thinking you want a permanent form of birth control.
People will often ask also during a C-section, well, does that mean I don't get to see my baby right away? Will I not get to breastfeed? Will I not get to do skin to skin or have that golden hour? It's a little different. And every facility is going to be different in their practice. But at our hospital, once baby's born, our NICU team is there just to make sure baby's doing well. And as long as you're feeling up to it, and baby's doing well, we usually bring baby right back to you during the C-section. So while we're closing all those layers and doing the latter part of the C-section, you can actually be with baby and do skin to skin. Mm-hmm. And if you're not feeling great, so if you're nauseous or just not feeling up
which definitely happens.
Yeah, a dad can do skin to skin. Mm-hmm. So, or a partner can do skin to skin. So we do definitely try to make sure that we get that skin to skin time or that bonding time as soon as possible. And then as far as breastfeeding, sometimes that'll happen in the operating room too.
Mm-hmm. Yeah. And to add on that, that we really want, if a patient wants that early bonding experience, we should be able to accommodate that in a C-section. But if you just need your moment there because you're going through a C-section and it's just, you're losing, some control in a way, and it's just like you need your moment, it's okay to say, you know what, I'll take the bonding time, when this is finished. I just can't, so it goes both ways a little bit too. So just communicate what you want, really, is what I'm trying to say.
So what happens if you just want a C-section? How do you talk to people about
good question.
Someone who doesn't even want to do labor, doesn't have a...
So someone, we're seeing them in the clinic and they're like, well, can I just have a C-section? I don't want to undergo labor. And I do see this, and, it's different, again, trying to fit, something safe into someone's, delivery plan. It is within your right to say, you know what, I don't want to undergo the labor process. I don't like the unpredictability of it. I don't, want to push a baby through my pelvis and vagina. It's within your right to say that. But I think it's also important to go over the risks, because you have to undergo, we talked about the risks in here, the anesthesia and all those things. So someone could say, hey, I'd rather just have a C-section. I don't want to go through all that unknown of labor. You could ask that. But do remember it's a major surgery.
Yeah, absolutely. And then oftentimes people will ask me, what's the difference in recovery from a C-section versus a vaginal delivery? And you may hear varying things on this, so this is just what I tell people, but the recovery, so it's still about 6 weeks, same as a vaginal delivery. It's just the first couple weeks can be a lot harder. You're just going to feel very, very sore. So anything that requires your abdomen, which if you've ever done a lot of sit-ups and then the next day it's really sore, basically everything, it just is sore. But we've got a regimen to help you. Our nurses are fabulous at working with you in the hospital. Oftentimes you'll stay an extra day from a vaginal delivery. So you'll be in the hospital a little bit longer, and just making sure that you're feeling comfortable before you go home.
Yeah. And, there's not a ton of great research as far as, what's the limit you can lift? What's the activity restrictions? What's the, and so a lot of that is kind of just things that are passed down, and it can be very different between each provider or clinic or hospital. But like Amy said, you're probably going to really want to take it easy, not lift too much heavier than 15, 20 pounds for the first couple of weeks. But then we want you to kind of get back to your normal activity, because the sooner you're able to get back to your normal activities, whether it's eating, walking around, those type of things, it helps the bowels return back to normal function, less constipation.
Prevents blood clots. We definitely want you walking.
Clots,
actually get you up walking pretty soon.
Should be up walking, hopefully within a handful of hours of the C-section. And it's good to see a lot of these trends of, the enhanced recovery pathways making its way to like the C-section realm, to try and get these moms to heal quicker and faster.
Absolutely. But ask your provider what their recommendations for restrictions are. And if you have a specific thing that you want to do, just ask them, and, it's your body. Make sure you can ask appropriately, know yourself what you should and shouldn't be doing after a C-section.
Well, perfect. That was a lot, but it was good. So we'll end there. If anyone has any questions, concerns, let us know. If you want to hear more about anything in particular, we can certainly break down a lot of these topics in further detail. And so happy to do that. We'll end the podcast there. Thanks for listening and viewing. If you have any questions, please let us know. Easiest maybe in the YouTube comments, or our email is out there. As always, the content of the podcast and video are for educational purposes only. None of the content is meant for personal medical advice. Please contact your provider if you're in need for personal medical advice. Thanks, everybody. Have a good day. Bye.